a fascinating and variable program, and he deserves just to start it. And then we start with the first talk by Vikas Menon. I think we always have half an hour for the talks, and I have to rush through the ways in trying to organize the changes from one to the next. But thanks so much, and I really think that the credit for this meeting goes to Sujit Kumar, who really had done an awful lot of work to put into this, and I don't know, he needs a lot of applause, which doesn't go through very well, but maybe you can put that in your charts later. Thanks so much, and Sujit, it's up to you now.
Thank you so much, Professor Renner. Good evening from India to all the participants of this conference. This will be a 2 days conference, 4 hours each on the day 1 and day 2, which is 6 p.m. Indian Standard Time to 10 p.m. Indian Standard Time. So I welcome you all to this conference. You all know that Global Psychiatric Association is a global association of mental health professionals, which is continuously working for developing scientific evidences for various psychiatric conditions, facilitating research through international collaborations. So Professor Rayner is the founder of this organization, and he's the editor-in-chief of Global Psychiatry Archives, which is running successfully since last several years. In this conference, because we all know that a lot of crisis is going on across the globe, may it be Middle East, may it be Southeast Asia, may it be America, may it be somewhere else in the world, some or other form of crisis is going on, and all those crises is having a significant link with the mental health. So this conference is basically going to address those mental health issues through the talks of multiple international speakers, young researchers. So we will be able to get a perspective of mental health perspective of different crises, different mental health issues from different corners of the world associated with whether it is terminal illness, either it is war disaster, whether it is related to the ongoing mental health issues, and so on. So we'll be having our presentation. Each presentation will be having 30 minutes of time, and maybe the authors can complete their presentation 20 to 25 minutes, and we'll have a 5-minute discussion. So for the first presentation, I will be inviting Professor Vikas Menon, who is a professor of psychiatry at JIPMER Pondicherry. It's a institute of national importance in India, South India. Dr. Vikas Menon is a prominent researcher from India whose primary areas of work are bipolar affective disorder, mood disorder, and particularly suicide. From India, he is the most cited and having the researcher with maximum number of publications in the area of suicide. He is continuously working for suicide prevention, and in the latest years, his area of work is mostly focusing on suicide crisis syndrome. So he has been listed as one of the leading researcher in the world in the Stanford list of 2% list of researchers in the world. So now I invite Dr. Vikas Menon to deliver his presentation on suicide crisis syndrome. Over to you, Dr. Vikas.
Thank you, Dr. Sujit, for the kind introduction. Thank you, Dr. Rayner, and to Dr. Sujit and the entire, the team behind this event for having me over here. So I hope I'm audible to everybody.
Yeah, you are audible. I hope, Dr. Rayner, you are recording the session.
Yes.
And
Yeah.
do I have permission now to share the slides?
I think you should have, but I should stop sharing mine here, and then you should have.
Yeah, I have shared it and I have now put it in the full screen mode. I just need a confirmation from somebody that it's actually visible in full screen. Okay, okay.
I can't see
Right.
it anyways.
I saw the thumbs up from Dr. Sujit, so I presume that it is good to go now. Okay.
I can't.
So yeah, once again, thank you very much for having me here. And as Dr. Sujit suggested, the last couple of years or a little more than that, I think about now, maybe, since the turn of the COVID, our group has been working on the suicide crisis syndrome. So my endeavor over the next 20-25 minutes is to give you an overview of what suicide crisis syndrome is. Some of you may be familiar, some of you may not be so familiar with this construct. And what is the validity and utility of this suicide crisis syndrome, which in fact is a very unique suicide specific diagnostic construct that is currently under review for inclusion in the future iterations of the DSM. So it is perhaps important for us as clinicians to know what the suicide crisis syndrome represents and how we can incorporate that into our clinical practice. So that will be my endeavor, and hopefully we achieve that, and then we could take some questions depending on the time. So this is how I will be structuring my presentation. Just a minute. Right. Sorry. Yeah. So first we will talk about an overview of the suicide crisis syndrome as well as the narrative crisis model of suicide, because the NCM is where the SCS is embedded and it's but one part of the overall narrative crisis model of suicide. So to understand the suicide crisis syndrome in totality, we also have to understand a bit of the NCM as well. So I'll just take you through that. And then we will definitely focus more on the validity of the suicide crisis syndrome, particularly in terms of the construct validity and the concurrent and predictive validity, which is what clinicians look for in any construct. And along the way, we'll also be talking about the validity of the model as well. And then the clinical utility of this particular suicide crisis syndrome and the narrative crisis model, that is how it can be clinically useful to clinicians and practitioners, and how best we can incorporate that in our day-to-day practice. And I hope the last two sections will give us some message about how we can clinically use this emerging construct in the best possible way as per our the current state of knowledge in the field. And then we will conclude. So with that, let's get started. So the first thing is, why do we need these new suicide specific diagnostic syndromes? The problem is that currently our field in terms of suicide risk assessment is not that advanced, especially the current risk assessment paradigms that we have today suffer from two major drawbacks. The first is that we are simply relying on long-term risk factors such as, for example, past history of suicide or family history of suicide to make judgments about acute risk, which is an approach that is prima facie faulty and for which there is little supporting evidence as well. The second major drawback of the current paradigms in suicide risk assessment is their excessive reliance on self-expressed suicidal ideation. Now, this is problematic because overtly expressed suicidal ideation may either be very transient and fluctuating, or people may have different motivations to conceal suicidal ideation when they talk to you. For example, fear of stigma, embarrassment, or confidentiality concerns, or simply they fear that if they reveal suicidal ideation, then it may have negative implications on their career or future or whatever it is. And the other issue is that sometimes, especially in impulsive suicidal attempts, the ideation is expressed or experienced just prior to the act, or sometimes never experienced at all, because it's also instantaneous and so sudden that there's hardly any time for this ideation to evolve before action. So because of all these reasons, I think we will definitely agree that reliance on overtly expressed suicidal ideation during risk assessment, which actually is the cornerstone of the traditional approaches, is fraught with issues. And tellingly, in a retrospective chart review that was published in the Suicide Life-Threatening Behavior, two-thirds of suicide decedents had denied suicidal ideation when they were last queried about it in their last mental health consult before they took their own life. And about half of them who denied ideation subsequently died within 2 weeks of the assessment. So that tells us at the least that, your reliance on suicidal ideation is is going to be risky, and it should definitely be complemented with some other factors as well. So even if you do ask for suicidal ideation, that's okay, but then you should not rely only on that one question to make a lot of judgments about the level of risk. So here is where the narrative crisis model of suicide comes in. So basically, this is a multi-stage model, and multi-stage models in suicide are those kinds of models which seek to explain how an individual progresses from distal risk factors to the current suicidal thoughts and behaviors that the patient is experiencing. And we have other multi-stage suicide models as well, that is like the integrated motivational volitional model of suicide. We have other models as well. So so the difference with this model compared to the other model is what we're going to see here. So in the narrative crisis model, I'm going to spend a couple of minutes on this slide to explain this to you, because this will give us a fundamental understanding of where the SCS fits in within the overarching narrative crisis model. So the start of the narrative crisis model is an individual with chronic risk factors for suicide. So that could include somebody with a history of suicide attempt, trait level features like impulsivity, hopelessness, or perfectionism, fearlessness to suicide, and fearlessness to the pain associated with the physical methods of suicide, and cultural acceptability of suicide or self-harm as a way of coping with one's issues. So in some cultures, these are accepted. So so these are some of the chronic risk factors for suicide. And what this model says is, when an individual with such chronic risk factors experiences some stressful life event, then those individuals progress to a subacute, predominantly cognitive construct called the suicidal narrative, in which the defining feature is excessively maladaptive views about themselves and the world around them. And the domains of the suicidal narrative are what's listed on your slide. So basically, it is kind of a dead end for the individual. When an individual experiences the suicidal narrative, they see, what do they see? They see a worthless past. They see, an intolerant present, and they see a non-existent future. So that all these things come together, and then they see suicide as a viable alternative now. And once an individual develops the suicidal narrative and begins to see suicide as the only viable alternative to their current problems, what they're facing, then they progress to the suicide crisis syndrome stage, which is a more acute cognitive affective state, in the sense that it has both cognitive and affective components, as you can see here. The predominant cognitive construct here is something like an entrapment, where they feel trapped in that situation, a kind of a hopeless situation, and they have some affective lability there, rapid spikes of emotional pain and negative emotions, and a very extreme kind of a anxiety bordering on the panic, and loss of cognitive control, where they're quite cognitively rigid about the way they approach problems and the way they try to see solutions to the problems, and basically they don't see any viable solution to the problem. They're not flexible enough to think about other solutions at that time. And hyperarousal, which manifests itself as hypervigilance, agitation, irritability, and then acute social withdrawal, where they withdraw into themselves and don't allow themselves access to their social circle and other protective factors. So once the suicide crisis syndrome develops, then the individual now begins to act upon their ideation, and then it results in suicidal behavior. So this is how the narrative crisis model of suicide envisages progression from chronic risk to the present suicidal thoughts and behaviors through the intermediaries of stressful life event, which is the trigger for the development of the suicidal narrative. So a stressful life event has to occur, and then there has to be a suicidal narrative, and then there has to be a suicide crisis syndrome, and then suicidal behavior. But then this model, the beauty of this model is also that it's very flexible. It's not that all these it also accounts for something like a very impulsive suicide where it may be more crisis driven rather than a narrative driven suicide where the individual can progress from the chronic risk factors directly to the suicide crisis syndrome stage as well, without a very prominent suicidal narrative in between. So the relative contribution of the suicidal narrative and the suicide crisis syndrome to the eventual suicidal behavior is quite variable depending on whether the suicidal behavior is narrative driven or more of a in which case it may be more of a planned lethal attempt, or it may be more of a crisis driven impulsive behavior as well. So that's the advantage of this model, in that it's quite flexible to account for different categories of suicidal behaviors. Right. The other important thing that you would have noticed while we were discussing this model is that self-reported ideation is not a milestone anywhere in the model. It doesn't figure anywhere, suicidal ideation. So that is how it tries to bridge some of the limitations of the current approaches, which rely a lot on suicidal ideation, express suicidal ideation during mental status examination. Right. So after having gone through that overview, now we will go to the validity of the suicide crisis syndrome, what the evidence says. So one of the earliest studies on validation of the suicide crisis syndrome was done in 2019, where the authors looked at the evidence for association between different SCS domains and suicidal thoughts and behaviors, past suicidal thoughts and behaviors. So this was a review actually of the various evidence in this regard. And it was from this initial examinations of the validity of the SCS that entrapment was found to be a very central criteria for SCS. So it has five domains, but entrapment, or the cognitive state of that frantic hopelessness, is one of the central criteria that should be there for the diagnosis of suicide crisis syndrome, along with one or more of the other four domains. So, and then they examined different combinations of these symptom dimensions with entrapment, that is, entrapment with affective instability, entrapment with social withdrawal, and so on, and found that certain combinations seem to predict prospective suicidal thoughts and behaviors better than the others. But then all combinations did predict with some reasonable validity as well. So that is one of the earliest studies that was done on the validity of SCS. Then subsequently, the SCS as measured through the suicide crisis inventory. So the suicide crisis syndrome is measured using suicide crisis inventory, which is a self-reported instrument which has gone through various versions during its genesis. So currently it stands at a 54 item SCI, and work is going on to develop shorter versions of it as well. So you can see that it has been replicated. The factor structure of the suicide crisis inventory has been replicated in various cultures and settings, including studies from our group in India, both in the general population as well as in individuals with major depression. So what are the main messages from this study? The main messages are that both there was support for both a one factor solution as well as a five factor solution. This shows that the SCS can be viewed as a one-dimensional construct as well, where you can take the scores in a linear manner and use it to judge who might be at higher risk compared to the other person, depending on their scores. And support for the five-factor structure solution indicates that the five criteria model of suicide crisis syndrome is also supported. And internal consistencies of the SCI2 total and subscale scores were good to excellent, indicating good reliability. And in terms of convergent validity, when they checked against other relevant measures such as PHQ-9 and GAD-7 for depression anxiety, there was good convergence. And in our study for discriminant validity, we tested these SCI scores against psychological resilience. That is the construct we use to check the discriminant validity, and there also we noticed associations in support of discriminant validity. So the SCS seems to have good construct validity, convergent, and reasonable discriminant validity as well. But obviously, the proof of the pudding is in the eating. So we're always looking at whether a good suicide risk assessment model is able to predict prospective attempts. So that's criterion validity, and the two types of criterion validity that have been evaluated are concurrent and predictive validity. So these are some of the studies that have looked at how the suicide crisis syndrome has been performing in terms of their predictive ability for prospective suicidal thoughts and behaviors. And these have also been done in several settings. The main messages from these studies are that the SES showed adequate concurrent validity. So concurrent validity was tested against past or lifetime suicidal thoughts and behaviors, and predictive validity was checked against even prospective suicidal thoughts and behaviors. So the association between SCS and prospective suicidal thoughts and behaviors was found to be significant. And this is where it is important. It was significant after controlling for the effects of traditional risk factors, like what we do in a traditional risk assessment, like these chronic risk factors like past and family history of suicide. So the SCS was able to predict prospective suicidal behaviors over and above traditional risk factors. However, some of the limitations of these studies are that only this has been evaluated in certain high-risk subgroups like psychiatric inpatients following discharge. And most studies were of short-term duration, so 4 to 8 weeks in duration. So the statistical power to detect these associations might have been compromised, because we know that as the duration of follow-up becomes longer, you get more events and more statistical power there. So that was about validity studies of the SCS, but the whole NCM model as such, that incorporates, all these stressful life events, the suicidal narrative and suicide crisis syndrome as a whole. Also, they have checked the model for its predictive validity. And this was one of the largest such studies that were carried out. It had a pooled N of 732, again, a mix of high risk inpatients and outpatients, and patients who followed up for 1 or 2 months. And this is very interesting that they applied a mixed mediation moderation model and serial mediation models to check the predictive validity. I'll just briefly explain the models that they tested for you. So this is the mixed mediation moderation model, where it's the same thing what we discussed earlier, but then instead of putting stressful life events as a mediator, they put it as an interaction variable between chronic risk factors and suicidal narrative. So that's why it's a mixed mediation moderation model. And in the serial mediation model, they included all components of the narrative crisis model as mediators. So you can see that it's all coming in serial mediation there below. In the first model, it was outside the mediation pathway, and it was an interaction variable. And let's see what they found then with both these models. So the mixed model significantly predicted past month and prospective 1 month prospective suicidal thoughts and behaviors, but interestingly, the interaction effect of stressful life events was not significant. The serial mediation model significantly predicted past month and 1 month prospective suicidal thoughts and behaviors. You can see that the square values are a bit more for the serial mediation model, indicating more robust prediction. And then the significant indirect effects of each mediator was found for past suicidal thoughts and behaviors, but for prospective suicidal thoughts and behaviors, indirect effects of suicidal narrative and suicidal crisis syndrome were significant. So in mediation analysis, indirect effects are what are more important than the direct effects, and that indicates that the effect is being mediated through the mediator of interest, and that is what. So there was proof for mediation by the different components of the narrative crisis model. So it actually shows evidence for the model and supports predictive validity of the entire narrative crisis model. And so basically, when you're looking at indicators of near-term risk, it allows us to focus on acutely observed affective and cognitive states, because that is what the suicide crisis syndrome represents. They're not something very distal that you're looking at. They're looking at what the patient is manifesting in terms of affective and cognitive disturbances when they are with you during the mental status examination. And none of the model's mediators involve suicidal ideation, as we have discussed previously, and therefore these kind of models offer us greater potential for customized interventions rather than what we're doing now, which is a one-size-fits-all approach in terms of suicide prevention. So really the potential here is that you can customize the intervention based on which components of the narrative crisis model are more prominent in an individual. Is it the suicidal narrative or suicide crisis syndrome, and so on. Right, so these are my last couple of slides. So in clinical utility of the suicide crisis syndrome is that, it's a suicide specific diagnostic state to aid suicide prevention. And as we discussed initially, there is a lot of theoretical and empirical grounding in the model in terms of theory as well as evidence. It appeals to the current knowledge regarding how suicide is driven multifactorially, and it may provisionally have better clinical utility and efficacy in reducing suicide outcomes. These are warning signs. We know there are warning signs that have been published with regard to suicides, which again is supposed to indicate near-term suicidal risk, but then these have not been empirically investigated and found to have good predictive value. On the other hand, the suicide crisis syndrome has been investigated, continues to be investigated, and the whatever results we have so far are very encouraging in this direction. It can be implemented in a wide variety of settings. Schools, communities, outpatient, inpatient. You could implement these risk assessment in a wide variety of settings. That's an advantage. And definitely it's more individualized than relying on traditional risk factors like past and family history of suicide to make judgments about acute risk. And you have validated tools like the suicide crisis inventory to inform clinical decision making. And in whatever studies they have looked at, they have assessed clinicians' feedback. In some studies they have done that, the clinicians have reported feasibility, acceptability, and helpfulness of this construct in their day-to-day practice. So we'll end with some thoughts on how best to utilize the suicide crisis syndrome in clinical assessment. So these are some thoughts from my side. This is not from any evidence, but some of these are supported by the evidence I've shown you just now. So it's probably meaningful to integrate suicide crisis syndrome measurements into your routine suicide risk assessments, as you do it anywhere in any setting. And then you utilize categorical assessment of suicide crisis syndrome to make admission and discharge decisions. In fact, there have been investigations looking into how the presence or absence of SCS versus the presence or absence of suicidal ideation is making a difference to the admission and discharge decisions. And this was done by blinded assessors, and they found that SCS, the presence or absence of SCS, correlated better with admission or discharge decisions than the presence or absence of suicidal ideation, implying that implicitly clinicians tend to rely on elements of the SCS. So we have an abbreviated suicide crisis syndrome checklist, which consists of 2 questions for high volume settings. Due to paucity of time, I'm not able to show you that here, but then the reference below my slide actually gives you the link to the article that has the abbreviated SCS checklist for you. So you could use that in high volume settings where the full SCS assessment is time prohibitive. And a positive answer to any of these 2 screening questions can be used as a prompt for full SCS assessment. So you could use a stage-wise approach like how we do for screening for depression, and then a full evaluation in busy settings. And then you could compare the outcomes with those of more traditional instruments like your Columbia scale, and see how prospective outcomes differ in follow-up between those who have gone through the SCS assessment and those who have gone through your traditional CSSRS assessments, the case pickup rates, the outcomes in follow-up between these 2 approaches, and so on. So that's some future research directions as well. So yeah, I'll stop here and I'll just conclude by summarizing some of the messages that the SCS represents a theoretically and empirically supported high-risk suicide state that does not include suicide ideation as a milestone anywhere in its conceptualization. And it's embedded within the narrative crisis model of suicide, which has also been independently validated, and each component of the NCM has also been independently validated. The SCS lends itself to convenient measurement using the SCI, the Suicide Crisis Inventory, both as a continuous measure and as a categorical measure, because there is the abbreviated Suicide Crisis Syndrome checklist as well. And there is preliminary evidence for the construct and predictive validity for the SCS and the NCM across cultures and settings. So perhaps another future direction in this for research is to have more randomized controlled trials that will tell us about the optimal method of treatment for suicide crisis syndrome. Is it going to be a pharmacological treatment or neuromodulation compared to treatment as usual, and whether the outcomes are superior once we diagnose and treat SCS promptly in terms of suicide prevention. I'll thank you for your patient listening and stop here, and back to the chairpersons. Thank you.
Thank you so much, Dr. Vikas, for as usual, excellent presentation. I would like to ask the participant whether there is any comment or questions. Dr. Vikas will be happy to answer that. You can ask directly or you can put your questions in the chat box.
Okay, just a quick question. We very often have people who, who just give it a little bit like a gamble. So they go to a bridge, want to stand there, want to go down. And so I worked in a city where the river goes through this town. So they stand there and then they're very committed to kill themselves and might do that later, but then they come back. So how would you integrate that into your model?
Yes, Dr. Rayner, thank you for the question. I think this is one of the common scenarios that we see. And again, so what I would do in this scenario is to talk to that individual and see where that suicidal drive is coming from. Is it coming from, for example, I can give you an example. Let's say an individual from Japan, where there is some cultural acceptability for suicide, and they get a low GPA average in their final exam and they feel despondent, and then they go to the bridge and look to jump off the bridge. There, the narrative, the suicidal narrative, is more of a perfectionism, failure, social defeat, and kind of a narrative. So if you have gone through that social narrative components, there are some components that might fit into that individual's narrative. So it's entirely about finding where the individual's narrative fits in with the suicide crisis, within the narrative crisis model. On the other hand, let's consider a school child who is being ostracized and bullied by his peers. So there, the story may be slightly different. It may be more of a social alienation kind of a narrative there, where they don't feel integrated into the society. So then it becomes a different approach there. So you have that's also the flexibility of the model, as I said, that it can explain different kinds of narrative and crisis driven suicides, and depending on where the individual fits in, then you can go for the appropriate formulation and management. I hope that answers your question.
Yeah, thank you.
Dr. Vikas, I just want to one more question.
Yes.
We all know that the media reporting is having a negative impact as well as positive impact in the suicidal behavior of particularly at-risk population. So you rightly pointed out suicide risk, suicide narrative, suicide crisis syndrome, subsequently leading to suicidal behavior. When we talk about the media reporting, when a vulnerable individual goes through a sensational media reporting about suicide story, so how it is going to affect the suicide narrative in a risk population? Can you put some light on that?
Yeah, I think this is another very good question. Thank you, Dr. Sujit. This has not been formally investigated to the best of my knowledge, how media, but then what one possible explanation I can try to offer is, for an individual who feels cognitively entrapped in their current life circumstance, when they see a media report of particularly of somebody facing a similar stressor and then ending their life, say for example exam failure, you read a media report of a student who belongs to the, say for example, I am the person who's contemplating, who's feeling entrapped because of my exams, and then I see a similar report in the media, then my entrapment and cognitive inflexibility comes in. So I now begin to identify with the media report and think that, okay, suicide is a viable alternative, and perhaps there is no other alternative because see, another individual also who experienced the same stressor has gone on to end their life. So then that, I think that entrapment and cognitive inflexibility just gets reinforced through that kind of media reporting. On the other hand, I think you could have a protective effect of the media reporting also. If the media is actually giving some alternatives like the Papageno effect and all, if the media is highlighting some alternatives to that circumstance, or the helpline number is probably prominently highlighted in that media report, then probably an individual who's not so cognitively rigid and willing to consider alternatives might also get proactively encouraged to consider those possibilities as well. So this is just a speculative answer from my point of view, but it has not been formally investigated. It's a great question to ask.
I think we have one more question from Tripsita Basu. How the model would you help in approach to identification and psychotherapy? So she's more interested to know about how the suicide crisis syndrome model help in identification of appropriate psychotherapeutic intervention for the client.
Yeah, so she has specifically asked about primordial and primary prevention. I think that's another great question because I actually had a slide on okay, because of lack of time, I don't want to take time to project it again. So I have actually written an editorial on this topic in the Indian Journal of Psychological Medicine. I could share the article sometime after I exit this. And there, so basically, to answer your question, let's say, for example, there is an individual with a childhood adversity, with a childhood sexual abuse, for example. That's one of the chronic risk factors that is there in the NCM model. Now, for this individual, they will have some sequelae of that childhood trauma, like say, for example, excessive activation of the HP axis and the stress diathesis responses and all. So you could consider even life skills education, life skills training in schools to increase their psychological resilience to deal with stressful life events in the future. You could consider some screening approaches to identify those people at high risk. So these are some of the approaches that you can use even in the early age groups to strengthen their resilience, so that, as I said, it's once an individual with chronic risk factors experiences stressful life events that they progress to suicidal narrative. So the whole approach there is to mitigate the impact of the stressful life events on those with risk factors. So you could offer support, training in terms of coping skills enhancement, resilience building, life skills training. So these are probably some of the approaches that you can use for primary prevention.
Dr. Vikas, there is one more question from Dr. Surbhi Chatterjee. So it is there in the chat box. Maybe you can answer that. That may be the last question we may be having.
Yes, to answer Surabhi's question, this is something we are planning to do, but we have not been able to get around to doing yet, because right now we are working on certain other aspects. But then, as I said, this is one of the future directions that we have for work. So, unfortunately, Dr. Surabhi, no clear answers right now for your question.
Thank you so much, Dr. Vikas, for your nice presentation and
Thank you, Dr.
responding
Sujit. I think Dr. Ibrahim has his hands up, if you may
Dr.
permit.
Ibrahim,
Yeah,
please.
yeah. I just want to ask about entrapment. Entrapment is key in the suicidal process. How this you think about addressing entrapment in the therapeutic process of suicide? How can you address entrapment? I think it's key in the suicidal person feeling entrapped,
Yes.
and entrapping is if you address it in the therapeutic process properly, it will be you know how can you address, because it is cognitive process. Entrapment, feeling if entrapped is cognitive process. If you do cognitive therapy on with him about entrapment, we feel unentrapped. Probably that
Yes.
will be good therapy for him if you do this kind of intervention.
I fully agree with you, Dr. Ibrahim. In fact, that is one of the interventions that is advised in the suicidal narrative, that is cognitive restructuring. You advise cognitive restructuring and particularly introduce some elements of dialectical behavior therapy as well, so that you can, and problem solving, so that they can reduce both their entrapment or consider other alternatives to their issue and reduce cognitive rigidity. So, but these are directions for future. So that is where we need more of trials, more of intervention trials. Now that the model has been validated, the next step is to go to intervention studies on the suicide crisis syndrome. But this is just picking up as of now. We don't have any hard data to show the evidence of these. But these are some of the stage-wise interventions that have been proposed. I'll put up the link to my editorial there, which talks about all the